Welcome to part 2 of our webinar on navicular syndrome in horses. In our first part we discussed the causes and the general symptoms and background to navicular disease or navicular syndrome. I think in this session we are going to look at the clinical examination and the imaging modalities that can be used to help us make a definite or as definite diagnosis as possible. Just at the end of our last presentation, we discussed the presenting signs that you as an owner may notice, and again, just to recap, at the early stages we get vague signs such as loss of action, stiffness, unwillingness to jump, and the horse maybe cannot lengthen his or her stride. We also, the owner may report some stumbling. It's more commonly seen in horses that are age 7 and over. However, there are exceptions to this rule, and we can see it in horses as young as 3. And even though it is more often an insidious onset, we have seen it acutely onset. The other point we made is that often that the lameness appears after a change in management, or maybe or soon after a change in ownership, and associated with a change in trimming and shoeing, or different work patterns, and perhaps altered periods of turnout in the paddock, or perhaps the horse is working on different surfaces. Clinical signs: some horses may point to toe while resting in a stable, and they may alternate pointing to toe. They may even pack the bedding under the heel. Although often a bilateral condition, one foot is often worse than the other. The horse may have a pottery gait, bilaterally shortened stride. Some may be lame in a straight line, but this will be more evident when trotting a circle on a hard surface. There are horses that will only show changes when they are ridden. Flexion tests, which we can see here, a picture of a flexion test being done on the left of the limb, they may exacerbate the lameness, but will not always do so. Some of you, will be aware of flexion tests being done when we're doing pre-purchase examinations or vetting a horse, and sometimes they're controversial because a flexion test will mean different things to different age groups of horses. So, for example, a top class show jumper that is doing a lot of work and is maybe 12 or 13, and you do a flexion test, he will nearly always be slightly positive, and there may not be that much significance attached to this because that's just the normal wear and tear. However, a flexion test done in a young untried horse that trots away lame, a vet will attach more significance. So therefore, a flexion test has to be interpreted in light of the age of the horse, the conformation of the horse, what work the horse is doing. Has to be taken part of the bigger picture. It is a useful piece of the jigsaw, but there can be false negatives and false positives with using flexion tests. We can see here on the right, we're using a hoof testers to try and put pain across the area of the caudal foot. This can be sometimes highlight pain, but not always. Equally, just to go back over to the flexion test, it's a fairly non-specific test. It's putting pressure on a lot of the different structures from the pastern to the foot region. So a horse that has a positive flexion test, i.e. trots away quite lame after the flexion test, doesn't necessarily mean it's navicular disease. It could be a number of conditions in that area. The next thing a veterinary surgeon will do, having identified the horse as lame and which leg it's lame on, we use nerve blocks, and this is where we use local anesthetic infiltrated around the nerves that supply sensation to the foot, and if the horse trots away sound, having this nerve block done, that then gives us an indication that the majority of the pain is originating from there. If the pain is coming from the foot area, This will eliminate the pain temporarily and improve the lameness. Without going into too much detail, there are a range of other nerve blocks to help pinpoint sources of pain. However, they are not totally reliable, as there are many other conditions in the foot, apart from navicular disease, that these blocks will eliminate pain from. So you can block out the nerves. We can actually put an interarticular block into the coffin joint, or a block into the navicular bursa. Again, the response to these blocks have got to be interpreted. It is not as black and white as you might think. In general, these blocks are relatively safe. However, you must be guided by your vet as to the advisability of doing them or not. And this especially applies to the navicular bursal block. Following the nerve blocks, x-rays are probably the next step that we're mostly familiar with. The interpretation of foot x-rays for both diagnosis of navicular disease and also as a predictor of the likelihood of a sound horse to develop navicular disease in the future is controversial. There are some cases where the radiographic changes are so dramatic that they are confirmatory. And for example, on the right here, where the arrow is pointing towards an erosion on the back border of the surface of the navicular bone, is showing very evidently a lesion and would be confirmatory of navicular syndrome. However, there are a range of changes found which may or may not indicate a problem. There are also cases when radiographs are completely normal and navicular disease has been confirmed by MRI. I would also say that there are cases primarily found during pre-purchase examinations where we had a perfectly sound horse and radiographs show up a number of these lollipops or areas of navicular that up till now we had thought maybe were predictors of development of navicular disease, and horses have failed vettings because of these, and many of these horses, even though they have technically failed on their x-rays, never went on to develop any problem. So a word of caution on the interpretation of x-rays for navicular disease. They can be fairly unreliable. These are cases of very obvious lesions. On the left we have a number of erosions on the bottom border of the navicular bone, which would be very suspicious of a problem. On the right, in the center of the navicular bone, there is a kind of a cystic area, which again would be very abnormal. In conclusion, x-rays are helpful, but they're not a reliable indicator. As we can see, if we go back to our schematics of the foot, there are an awful lot of other structures in the foot apart from bone, and radiographs only show us bone. There are soft tissue structures. We have got deep digital flexor tendon, got the impar ligament, we've got the suspensory ligaments of the navicular bone, we've got the collateral ligaments between the coffin joint, around the coffin joint, and other soft tissue structures. Radiographs do not show these. The also thing about radiographs is radiographs do not indicate the activity of a lesion, whether it is active or not. It's kind of a historical information. In this case, we have a fracture of the navicular bone. And interesting thing about navicular bone fractures is they're a rare enough occurrence. They can happen simply. Sometimes actually a horse just jumping down off a lorry, and that impact can cause a fracture of the navicular bone. Treatment usually involves complete rest for up to 4 to 5 months. Many horses can completely recover from fractured navicular bones, but interestingly enough, the fracture line will never go. So this fracture here, we don't know if that fracture is a month old or 4 years old. So X-ray interpretation, unfortunately the cases where obvious changes are visible on radiographs are only in the minority. X-ray changes are generally subtle, and many horses with navicular syndrome have no radiographic findings. This leads to both false diagnosis of navicular disease and misdiagnosis of the syndrome. Furthermore, it is our view that radiographs are of limited value as predictors of disease. Other imaging techniques, and we will first here talk about scintigraphy, which are bone scanning. This is our bone scanning unit, and this involves injecting a radioactive isotope into the horse's vein. This travels around the bloodstream, and after traveling around the body, the isotope or the radioactive isotope settles in the area of high bone damage or activity. This is a routine enough procedure in human hospitals and is perfectly safe, but it has to be done under strictly controlled guidelines. A gamma camera is then used, and we can see the gamma camera here on the right is used to take images of the bone, and if there is an area of bone inflammation or high bone activity due to a fracture or inflammatory, there will be an increased signal from that area, giving rise to a hotspot. It offers a sensitive method of diagnosis of navicular disease where bone pathology is the primary problem. It will not show us any problems if there's a tendinous injuries. Here we've got two examples of hotspots. There's a lateral view on the left where the arrow is pointing towards a hot area around the navicular bone, and again on the right, which is on a picture of a foot, of the bottom of a foot, and you can see the very hot spot in the center around the navicular bone. Thermography, I just mentioned in passing. I do not think it has any role at all in the diagnosis of navicular disease. We had used a thermography camera for a number of years at Troytown, but we now no longer use it. Thermography really only picks up changes of heat at skin level, and it is used now in some FEI competitions on detecting whether horses have had blisters or counter irritants put on their skin, which is a very sensitive indicator of that. But as something useful for lameness diagnosis, we haven't found it useful and no longer use it. This leads us on to magnetic resonance imaging, or MRI. And the advent of MRI has revolutionized the diagnosis of navicular disease and other causes of foot pain. X-rays and even bone scanning only give information about damage to bone. MRI, on the other hand, gives exquisite detail of all the structures in the foot, including tendons, ligaments, the joint capsule, the laminae, the bursae. The detail of the bone on MRI is also far superior. There are cases, as I mentioned earlier, of confirmed navicular disease where the X-rays are completely normal, but on MRI we can see changes of the navicular bone showing what we call bone oedema or inflammation of the bone. MRI is extremely sensitive. MRI has added a new list of injuries that we're previously unaware of. Tears of the deep digital flexor tendons, inflammations of the impar ligament, injury to the distal digital annular ligament, navicular bursitis, synovitis of the coffin joint, collateral ligament damage of the coffin joint, lesions of the coffin bone, including cysts and some hairline fractures that were not visible on radiographs. Here, just give an example of some of the detail that MRI will give you. On the left, we have an anatomical cross section of a cadaver of a horse's foot, and on the right, we have an MRI image, and we can see where all the structures that were visible on the left are visible on MRI scan. Here we have an example of some new injuries only identified by MRI scan. On the right, with the yellow arrows, is showing a tear in the deep digital flexor tendon. On the left, we have an injury of the suspensory ligament of the navicular bone. We've got a few more images here, and the one thing about MRI is we take numerous sections of the bone, so it's not just on any one X-ray. You might have up to 6 views, but with MRI we can have 100 views, all in different planes and sections, so we can get incredible detail of what's going on that foot. And these images here are showing 2 separate cases of tears of the deep digital flexor tendon. On the right, we've got a horse with a navicular cyst in the navicular bone, which was not evident or just about evident on radiographs and needed MRI to confirm its presence. On the left, we have got inflammation of the navicular bone or oedema of the navicular bone, indicative of navicular syndrome, which again was not readily evident on x-rays. On the left, we have an image of a horse with a collateral ligament injury. The collateral ligament is a ligament supporting the pastern bone to the coffin bone. On the right, we have an area of torn deep digital flexor tendon and oedema of the affected navicular bone. This is just a comparison of the detail between radiographs and MRI. On the right, we have a radiograph, and I think you can see the difference in detail that the MRI gives us and the amount of information that the MRI gives us as compared to standard radiographs. Having finished all these diagnostic techniques and imaging, we can then come to a reasoned diagnosis as to what is going on in the foot area. And depending on what we have diagnosed, depending what type of injury we have, will direct us towards treatment options. Of course, not every horse is going to have an MRI or bone scanning done, and a great deal of the time it will just be radiographs and clinical examination and nerve blocks. However, we would argue that in the longer term, more and more horses will have MRIs done, because there is great value in an accurate diagnosis. Even if it does identify that there is so much damage that the horse is very unlikely to make a recovery. I think that's a very important thing to know, because rather than wasting 6 or 9 months trying to get a horse that otherwise would not come right, saves a great deal of time and money and grief to an owner. Also, there is great value in definitively knowing the diagnosis rather than guessing. It might be a deep digital flexor tear, it might be navicular oedema, it might be bursitis. The MRI gives you the certainty of knowing exactly what's going on, and you can then concentrate your treatment options to that specific diagnosis. I think too often, before we had the advantage of MRI, we made a presumptive diagnosis of navicular, and we would start treating the horse for the navicular problem, and maybe after a month or 2 months we weren't making any progress, and then we might doubt our diagnosis and change tack, when in actual fact we were treating the right condition, but probably not intensively enough. But because we hadn't got an absolute definite diagnosis, we had lost confidence in our diagnosis. That is why we would advocate that the MRI is that when you are sure of your diagnosis, you will then redouble your treatment efforts specifically on that problem, and will not get waylaid by a initial poor response to treatment. So that is the end of this second webinar, and in our next webinar, which will be coming up shortly, we will discuss the various treatment options open to us.